Thank you. Okay, so let's just finish up again with acute bronchitis. Let's try this again. So again, the causes will be mainly viral. Okay, so just keep that in mind. Although, again, it could be bacterial infections, okay, that could cause this type of bronchitis. And they list here all the different viruses. Now, here are some of the non-viral causes, so just please take a note of those. I would say just memorize these just to be on the safe side for test purposes. I'm not sure which one I'll put on the test, whether a virus or non-virus, so just kind of memorize those two slides. Some of this stuff I don't know if you took a look at in micro. Okay, anyway. Now, some other causes that are not microbial could be heat, smoke inhalation, inhalation of different irritant chemicals, and allergic reactions. So even people that are smokers, chronic smokers, they can start to develop sort of an acute bronchitis. And this is usually what happens. So say, for example, a person that's a smoker, smoking for years and years, they'll maybe start to develop like this chronic, bronchial infection, and then it could turn into a chronic bronchitis, and then God forbid it turns into something else, okay, like an emphysema or whatever. So just keep that in mind. Now the pathogenesis here with acute bronchitis is pretty much the same as asthma, but just two little differences. So the airway does become inflamed. Okay, the capillaries do become dilated, okay, because they do swell, because they do have the same type of fluid, okay, that is secreted, just like with asthma. The other thing here is that there is an infiltration of inflammatory cells that will increase mucus production, much like asthma. Now, this is something different that we did not see in asthma, okay, which is what I would highlight. With these individuals, they have loss of ciliary function. So remember that the respiratory epithelium is ciliated, pseudostratified, columnar, whatever type of epithelium. And so keep in mind that the cilia is here to pull out or sweep away any type of irritants that come inside the airway. So when they lose ciliary function, these individuals are going to have a hard time, obviously, pushing out those types of irritants. Also, they do lose portions of the ciliated epithelium. And this is actually more common with the individuals that are smokers or people that inhale these type of chemical irritants, okay? So just keep that in mind. So smokers, and I think I explained to you what happens with smoking, right? So when a person inhales and constantly taking in that smoke, what happens, it's a constant irritation that's happening to the respiratory tract. And then not only that, the chemicals in the cigarette smoke will actually start to strip away that epithelium, especially tearing away the cilia and also tearing away and breaking down that epithelium to like a simple squamous almost, okay? So hence the reason why, if you know people that are chronic smokers, they always have this chronic cough, okay? They're always coughing, coughing, coughing. Because what's happening is that the body that can normally sweep away certain irritants that come in, they can't do that anymore, okay? Because of the deterioration that happens. But for the smokers, not to scare you, it is reversible, okay? So once you stop smoking, it is reversible. Now, along with acute bronchitis, yes, they do have a cough. It could be productive or non-productive depending on how much mucus they're producing. They can have a low-grade fever, and this goes along with if they are having any type of viral infection that's going along with this. Chest discomfort, sore throat, okay, which kind of goes along with that whole viral thing that they may be having. Post-nasal drip, if you ever experienced that, that's not a good feeling, okay? And that just kind of goes along with, again, the viral infection. So when they have the influenza, the cold virus, these are just the common things that kind of go along with that. Now, the diagnosis here is quite easy to diagnose, okay? Although, when a patient has signs and symptoms of acute bronchitis, sometimes it is pretty much the same types of signs and symptoms of a patient that may have pneumonia, okay? So what will happen here is that they will do, and I don't know if this is something that's a protocol, but they say that a chest x-ray is used to distinguish acute bronchitis from pneumonia. Now the thing with acute bronchitis and pneumonia, say for example, acute bronchitis is the acute inflammatory process that's going on. So these individuals will have some sort of infiltrates, and what I mean by infiltrate, sort of like these cells, okay? So the immune cells, you can see if they're in a cluster format, okay, in the chest or the lung field. But with patients that have pneumonia, they have more of a consolidation type in the lung field. So whereas, say for example, bronchitis, you may see a few little cells around or little white spots, so to speak. Whereas if you see a person with pneumonia, it's more of a consolidation, so like a larger area, okay, of these type of immune cells. When you look at chest x-rays of pneumonia, you'll know it when you see it. It's quite, did you guys go over pneumonia in micro? I'm not sure if you went over that, no. It's okay, I wasn't sure. But in any event, you'll know it when you see pneumonia. Okay, now the treatment, antibiotic therapy, and as I talked about this earlier, if it is bacterial, I think we all know by now that antibiotics are given for bacterial type infections, although unfortunately it is overused, okay, as you know. And what happens when a person has acute bronchitis, just like any other viral respiratory thing, what you do is take some fluids, rest, take some cough syrup, and that's it, and just relax. And what will happen is if the person is healthy enough, the body will take care of it. Okay, so antibiotics are not needed for anything that's viral. And they put here avoid smoke and definitely use a vaporizer in the bedroom so it can help increase the airflow as far as an inhale and an exhale. Okay, so that's acute bronchitis. Now, chronic bronchitis is different. Chronic bronchitis is actually something that is definitely more severe, and we will go over all the little details of chronic bronchitis. They do consider this type B COPD. Type A is emphysema, which we'll go over next. But they do also call these individuals blue bloaters, and I see this in a lot of textbooks, but from what I hear in the field, I don't think they call them blue bloaters, and I'll explain why they call them blue bloaters in a second. But these individuals do have a chronic, recurrent, productive cough over 3 months to 2 years. Now, if anybody's coughing the almost 2 years having the same cough, that's a problem, okay? So please keep in mind that, and what happens with these people, most of the times these are smokers, okay? And I will say that. Most of the times these are smokers. And what happens with patients, and I'm sure you guys will see this time and time again, people know something's going on with their bodies, okay? And they know something's wrong, but they don't want to admit it or, you know, want to go through the steps of it. So, unfortunately, they will come in and say, I've been coughing for a year, okay? And the same type of cough. And they're thinking, oh, it's going to go away or what have you, or thinking it's going to take care of itself, but it is a persistent cough. Please keep in mind that chronic bronchitis is irreversible, and I'll show you why in a little bit when we go into the pathophysiology of it. They do say that typically these patients are overweight, okay? Not the reason why they call them bloater is for the edema, because a lot of people think, oh, the blue bloaters because they're bigger, but it's really more because of the edema that they get. And these individuals are around the ages 30 through 40, or over 30 to 40. They say commonly associated with emphysema, but from my understanding, chronic bronchitis can occur first, and then the person, if it gets terribly, you know, worse than that, I should say, it could go into an emphysema. Now, here we go. 90% cigarette smoking. So this means smoking. Okay, so there's nothing else to really say about that. And you'll see. Repeated airway infections. Some people can have a genetic predisposition for it. I don't know the percentage on that, but it's not a high percentage that is genetics. Again, most of it is smoking. And then sometimes people can inhale certain irritants, especially if they're around a certain work environment, that can cause them to have this chronic bronchitis. Okay. So the pathogenesis here, again, not too much different than asthma and acute bronchitis, with just a few little different things here I'll go over. So they do have a chronic inflammation and swelling of the bronchial mucosa that can result in scarring. So let me explain what happens here, and this will make sense, the words. once they do have this sort of irritant, okay, so say they're smoking, they're puffing away, okay, for years and years, and this irritant now will cause this immune process to happen in their bronchial tree. When this immune process happens in their bronchial tree, you know you have neutrophils, you know you have lymphocytes, all of those white blood cells, everything's going to come to the area. But as I told you before, what happens is that when certain cells are secreted, especially a lot of the immune cells, they come to the area and it's like a crowding, so to speak. And they're not only crowding, they do a lot of damage. So they're trying to get rid of the situation that's going on, but it's causing more damage to the epithelium. Okay? So please keep in mind and know all of this information here that interleukin 8 levels, once they're elevated, they will recruit the neutrophils, okay? And I'm not sure if you remember that information from physiology, but interleukin 8 will recruit neutrophils, and so neutrophils, again, as we know, the first ones on the scene. CD8 T lymphocytes will be also elevated, and keep in mind that our lymphocytes are definitely going to be there, our white blood cells are there to try to attack whatever it is that's being introduced into the body, so whatever that irritant is. It can extend into the surrounding alveoli. And this could be an issue because we know that the alveoli is where gas exchange takes place. So if you now get a lot of inflammatory cells and scarring and a whole bunch of congestion, so to speak, at the alveoli, the problem is these patients are not going to be able to have proper ventilation, okay, of gases. So that could be an issue. So it can prevent oxidization, okay, in that sense. Now, the other thing, just like asthma, they will have a hyperplasia of goblet cells, okay? And they should have used that term with asthma as well. But I do want you to know that it's a hyperplasia. That is a cellular adaptation that occurs in asthma and also chronic bronchitis, which is a hyperplasia of goblet cells. Now we know when there's a hyperplasia of goblet cells, this is obviously going to increase more mucus. More mucus in the airway is going to be obviously more trapping or congestion. Okay, so they're showing you a picture of the epithelium, and that's not a big deal. Now, the pathogenesis here also is that because we have mucus and all these exudates and everything's just clogging up the airway, the bronchial wall becomes thick. Now, when the bronchial wall becomes thick, what the body recognizes is that, hey, we're not being able to have proper ventilation as we're supposed to, so it's actually going to work harder, okay? So it's actually going to have a resistance to increased work of breathing, increased oxygen demands, because we're not being able to inhale and exhale as we should, or especially inhale. So these patients will have hypoxemia, which is low oxygen, and this is, I think this will be hypercapnia. It's hypercapnia. Oh yeah, increase in carbon dioxide. So they have two terms, I guess, for the hypercapnia and capnia. Okay, hypercapnia and capnia, which is increase in carbon dioxide. Now, when you have this situation, this can increase pulmonary artery resistance. If we have an increase in pulmonary artery resistance, what is something that you think could happen with the increase in pulmonary artery resistance? Not saying it always happens with these individuals, but what could happen? You're kind of on the right track. But what type of blood pressure? What type of hypertension? Pulmonary hypertension. Okay. So not to say that it will always happen, but these patients could lead into a pulmonary hypertension if they have an increase in resistance there. Now here's a picture of an alveoli. Okay, I don't know if you remember what a normal alveoli looks like in anatomy, but what is the problem here with this alveoli? So just to let you know, this is the epithelium of the alveoli, just to help you get your bearings. And this is the inside of it. Okay. All of this should not be here. Okay, if you remember the alveoli, if you remember the alveoli, it's supposed to be clear inside. Okay, so you have just your squamous epithelium, and the alveoli is not supposed to have anything in the alveolar sacs. Why? Because we know that that's where the oxygen and carbon dioxide is supposed to exchange. So we don't need any extra anything inside the air sacs. So all of this that you're looking at is inflammatory cells. Okay, that is just pretty much pulling up around that alveolar level. So obviously, just by looking at that, this just looks like congestion, so you know this person can't breathe. Okay. So here we go. I already talked about this. Pulmonary hypertension, which I was talking about a little bit in the previous slide. So pulmonary hypertension, inflammation in the bronchial wall, will cause a vasoconstriction, okay, of these blood vessels. And if this person has pulmonary hypertension, please understand, if you know, remember your blood flow, if there's pulmonary hypertension, this could lead this person into having right-sided heart failure, okay. So understand the pulmonary artery. Okay, if there's a hypertension there, meaning that blood is just backed up, okay, causing this sort of hypertension or I shouldn't say mismatch, but altered pressure, so to speak. And what will happen is it'll back up and now cause this backup of blood and can cause these individuals to have right-sided heart failure. Okay. Now, clinical manifestations, okay, SOB. Not that your patients are SOB. This is shortness of breath. Okay, SOB is shortness of breath on exertion. And these individuals, and when we say exertion, I don't want you to think like they're running, 5 miles in shortness of breath. This is just mild exertion. Okay, so say for example, you guys walk up the stairs every day. Okay, and walking up the stairs like that's enough for those patients. Okay, so just mild exertion. Excessive sputum, we already know because they do produce a lot of mucus. Chronic cough. And the thing with this is, and I was watching a case study with this, these patients will say that they have this cough more severe the morning. So I guess from laying down all night, okay, and everything's just kind of settling, and then when they get up, there's just so much mucus, okay, that just kind of accumulated. Evidence of excess body fluid, so they will go into a state of edema. Please understand why they're going into an edema. Why do you think they're going into an edema? Okay, very good. Fluid is leaking into the interstitial spaces of the tissues. But keep in mind that extra fluid that's leaking is coming from the backup from the pulmonary system. Okay, so keep in mind that they're already most likely at a state of having pulmonary hypertension, and blood flow is not the way it should be. So what's going to happen at the capillary level, they will start to leak these fluids, and these fluids will build up in the tissue spaces. Okay, so I just want you to understand the physiology behind how they get the edema. Okay, and then cyanosis, they say is a late finding. And cyanosis, as you know, is when they do have very extreme oxygen loss. And oxygen, not only just oxygen loss in the bloodstream, but also to tissues. So this is when individuals do start to have the blue lips, okay, and the blue fingertips, okay, the nail beds will start to look blue from the lack of oxygen. So this is what they look like. So this is what they call a blue bloater. Blue because of the cyanosis, okay. So blue to cyanosis, so again, the blue lips, blue fingernails. They call them bloaters because of the edema. So they do get a lot of tissue edema. Although these individuals are probably overweight to begin with, but then they also start to gain more water weight, so to speak. Chronic cough, shortness of breath we talked about, yes, and increased sputum. And the sputum, just to let you know, when I was looking at it, I had a video of a case study, but I don't have time to show it. The sputum, from my understanding, is more like a yellow or green color. Okay, so not to be gross, but that's what the color. So it's like a yellow greenish type of sputum. Now, chest x-ray can be performed And when the chest x-ray is performed, just a few things I want to just highlight here. Congested lung fields. Yes, the lung fields will be congested because, as I showed you with the histology slide of the alveoli, all of those inflammatory cells and all the exudates, everything is just there, just sitting there. Okay, so that can actually be seen on x-ray. You can see it'll actually show up like little white spots, okay, in the lung field. Enlarged horizontal cardiac silhouette, which means that when we have this sort of pulmonary hypertension, or say for example if these patients do have right-sided heart failure, we know that there's a backup of blood. So what's going to happen, the heart is going to get hypertrophy, which means it's going to get enlarged. Okay, so you'll see the silhouette of the heart just a little enlarged. And evidence of previous pulmonary infection, which can also be seen on the chest x-ray. Pulmonary functional testing, just memorize this just to be on the safe side. So normal total lung capacity and increased residual volume, which we know because they have more air getting out, and decrease of forced expiratory volume. So when they try to exhale, that is decreased volume. Now, arterial blood gas, so elevated carbon dioxide, which we could imagine, and decreased oxygen. Okay, so that's easy enough. Now, ECG. ECG is done on these patients, and what will happen here is that they could have atrial arrhythmias. Why do you think, and I'm going to see if you guys can walk through the pathogenesis of this, why do you think they would have an atrial arrhythmia? Meaning that the atrium is not, the signal, I should say, well, when it contracts, it's not contracting as it should, and it's causing the off rhythm in the atrium.
Maybe the arteries are being cycled from all the lung.
Very good. So keep in mind the pulmonary artery that's in its hypertensive state, so pulmonary hypertension now is causing a backup of blood on the right side of the heart. So if you have blood that's stuck in the right ventricle, when the blood that's in the right atrium is trying to push forward and contract and push forward, it can't because there's too much blood. There's nowhere for that blood to go. So instead of the ventricle having the arrhythmia, which is not, it's the atrium that's going to have an arrhythmia because that's the one that's trying to contract and push the blood down. Is everybody with me? So just understand why they have an arrhythmia. They could also have right ventricular hypertrophy, and again, that is because of the blood that's stuck in the heart. So they have a backup of blood, and again, that comes from the pulmonary hypertension. Okay. The other thing that can happen is these patients could have a secondary polycythemia. Okay. Polycythemia, if you remember, I think we talked about this a little bit with the vascular system. Polycythemia is an increase in red blood cells. Now, why do you think that they would have an increase in red blood cells? This is a compensatory mechanism. Why do you think the body is going into this compensatory mechanism of increasing red blood cells?
Oxygen.
Very good, to increase oxygen, okay, because these patients are depleted of oxygen, so the body recognizes that. And the compensatory mechanism is that they're going to have an increase in red blood cells. So it will lead them into a polycythemia. So again, keep in mind that this is a compensatory mechanism that happens with this. Now, treatment for chronic bronchitis, inhaled B2 agonist, which we know is a bronchodilator. Then they also have another type of bronchodilator here, cough suppressants. They can give them something for bacterial infections if they have that. What happens too with these individuals, they can also start to get subsequent bacterial infections because of everything that's going on with them. Corticosteroids, which we know relax the airway, and theophylline products. I think this is also something to decrease the infections, if I'm not mistaken. I apologize. I thought I had notes on that. Okay, so those are the medications. Now, another treatment, and this is obviously if these patients need oxygen, if they do get depleted of oxygen, low-dose oxygen therapy patients that do have oxygen levels that are below 55 millimeters of mercury. Now keep in mind, and I saw this in the case study video that I was talking about earlier, that these patients that have an acute bronchitis, if those oxygen levels drop very low, they can go into a respiratory distress. Okay, so I want you to understand that, and that is obviously an immediate situation that needs to be handled. And one of the things is, yes, definitely giving them oxygen. The other thing that you would manage your patient with chronic bronchitis is telling them to stop smoking. That is the number one thing you would tell them to do, because again, 90% of this comes from smoking. Bronchodilators, making sure that they're taking their medications properly at home. Making sure they also get rest, making sure they also have proper hydration, and also physical conditioning, getting that weight down, because that also puts a lot of strain on the heart, and not just the heart, but the whole cardiovascular and respiratory system. Okay, so we're done with that. Now, emphysema. Yes?
I was just wondering, where are you getting these little movie case studies? Are they on like YouTube?
Yeah, on YouTube. If you type in on YouTube and just kind of always type in, like, say, for example, chronic bronchitis, and then put in animation. And they had like a case study animation. It was kind of funny. It was sort of like a spin-off of what's the medical show? House. Not House. Not Scrubs.
Grey's Anatomy.
Grey's Anatomy, yeah. Because they had the Dreamy and all that. Yeah, so it was like a spin-off like that. But it was a really good case study, though, of the patient with chronic bronchitis. But they used the characters in Grey's Anatomy. So that was on YouTube.
Would you say that would be helpful in like...
It would be helpful. I can try to, on the next break, I'll try to pull it up for you. And I'll give you the exact link for it. Okay. Okay, now, emphysema. This is the last one that we're going to go over with this chapter, okay? So with emphysema, this is considered type A COPD, okay? And they call these individuals pink puffers, okay? Now I know we got blue bloaters and pink puffers. Now the pink puffer, they call them pink puffers because their tissues, actually the skin gets like a pinkish color, and puffer because of the way they have this sort of pursed lip breathing that I'm going to go over and show you in a second. What happens here, most of the times this is older individuals. But if it does happen in young to middle-aged people, they do believe it's hereditary. Okay, so not so much from smoking. But most of the times, again, this is another type of smoking-caused disease. But if it is hereditary, these people do have what is called low alpha antitrypsin. Now, if you remember from physiology, antitrypsin is something that actually protects the alveoli of the lung. Okay. So if they don't have that protection, which is the antitrypsin, then this obviously will lead them into an emphysema. But again, I'll tell you a story about a chiropractor I used to work with, and he smoked for years, a long time. And he started out with a cough, so he probably had like a bronchitis, or maybe it led into a chronic bronchitis. And then it led into, he got a diagnosis of emphysema. And it was so bad, and people with emphysema, if you've ever seen individuals with this, they really have extreme shortness of breath with just any exertion. So if he was to walk from that door to that printer, he would be done. Like, he would have to sit down and really be done for like half the day. So they really, really have compromised.
How did he be a chiropractor, like climbing on people?
Well, he couldn't. It actually got to the point where I actually took his patients over because he couldn't work anymore. So he got very ill. Patients with emphysema are very ill. They're not active, and it's not one of those things that are reversible, unfortunately. And the sad thing with him, once he was diagnosed with emphysema, he actually was diagnosed with throat cancer. And he died, I would say, like maybe 10 months after that diagnosis. And the other crazy part to this story is that at the funeral, his wife's outside, we're outside the church at the funeral. What do you think she's doing?
Smoking. She's like, oh, yeah.
So it's one of those things, you know, smoking is, and not to get on the people, because I know people smoke in this class, but not to get on anyone that smokes. It's just, this is just what happens, you know. is what it is. Okay. Now, this is a person's lung with emphysema. And what they're trying to show you here with this picture, this is not a great picture, but along with this picture being this color, you know how they say this is what your lungs look like when you smoke and they show you the black lung? It's true. Because what happens is that all of the chemicals from the cigarette smoke, it stays in the lungs. And so it will turn the lung this black color. If this was an individual that had emphysema that maybe wasn't smoking, maybe was hereditary, probably wouldn't be so black. But this is probably someone that was smoking. Now, what will happen here is what you'll see is that the lung kind of looks porous. If you took a picture or took a look at the lung anatomy, and I know it was kind of hard with the little piglets, but with that lung, you saw that it was just kind of nice and smooth, okay? You don't see it just like kind of holes, okay? When you see holes in the lung, this is definitely along the lines of emphysema, because what this means is that the alveoli are destroyed. When the alveoli are blown out and destroyed, it actually gives this appearance that kind of looks like, I don't want to say honeycomb, because I don't want to use that term for this, because I think we have another honeycomb lung that we use for something else. Sponge, thank you, like a sponge. Okay, so it looks just like a sponge, and this is definitely the emphysema here, and this is a normal looking lung. This is not a great picture, but I think they kept this in here for me. Okay, so smoking over 70 packs per year. Now that sounds like a lot. I remember one class somebody said, "Oh, that's not a lot." I don't know, but I don't know what that is. You know, what's a lot? What's considered a lot? I think that's a lot. But in any event, that's usually the #1 cause for smoking. Air pollution can also cause this sometimes, and sometimes when people do work in certain environments, such as like being around welding and cold and things of that nature. And again, if they do have that alpha antitrypsin deficiency. Now, this alpha antitrypsin deficiency, please understand that people are sometimes born with this. So it is a hereditary thing. So they could be born with just not having enough alpha antitrypsin. That could unfortunately lead this situation. But again, most of the time it's smoking. So what happens here, smoking causes the alveolar damage. Okay, and I think I talked about this time and time again, is that when this cigarette smoke and it gets inhaled and gets into your lungs, what will happen is that it will definitely lead to a release of these enzymes. These enzymes, part of the inflammatory process, will now start to break down the respiratory tract. The problem here is that when it breaks down the alveoli is very, very thin. It's simple squamous. So if it starts to break down the alveoli, it will start to strip it, and then what you have left is, and it doesn't strip it to where it just kind of blows, like makes holes in the alveoli, but it kind of tears away the cartilage and the fibers, you know, that make up the alveoli. So it makes the alveoli going from the nice small grape size to making it large and blown out, because it just kind of strips it and stretches out the whole epithelium of it. So that's the issue here. It inactivates the alpha antitrypsin, which means that protection that they have at the alveoli, or what they also call the parenchyma of the lung, is gone. So they don't have any more protection, which means when you try to have that nice little tight little grape size, you can't, okay, because now that it's destroyed and blown out, and then you really don't have enough